I'll wave back. Cheers. Thank you. Right, well, give me to this evening's webinar. And what we're going to do tonight is have a chat about nails. Now, we've had a talk about nails on the previous webinar, so it proved to be quite a popular subject. So we decided to put together a little more information.
These came back from a search.
One of those nights, hang on. I'm trying to turn the phone on. There we go, power off, excellent. Right, so we've put together some extra information, and we could do time after time after time on nails, because it is such a huge subject. If you look at any of the accepted sources of information on nails, like my particular favorite one, which is Barron and Dorber, as you can see the size of it, and they don't repeat any words in that at all. And it's all about nails. Good 100 quid's worth if you ever want to buy it. Now, I don't actually know whether that comes within our discount scheme. Does it, Jill? Jill, wherever you are?
I'm here. I'd have to look into that one for you, whether it does come with a discount, but yeah.
Blackwell Science, that is. Because I know we've got a discount scheme with one of the publishers. I can't bring to mind which particular one it is at the moment. But something like that is a great source of information. But what I'd like to do now is I'll start to share a PowerPoint with you. As I go through the PowerPoint, then if you have any questions that you'd like to raise, if you put them in the chat box, then Jill or Kirsty can interrupt me at a suitable moment, and I can answer the questions that you've got. Obviously, this presentation will be available to you. If you ask the office, they'll be able to send you a copy of the presentation, so you can look at it at your leisure, so you don't have to scribble notes unless you particularly want to. So let me get in and start the presentation, and then we'll start working our way through it. And we've got a full house tonight, I see. A lot of people from all over the world. Well, we've got some as far away as Scotland, I mean, at least. So just bear with me. Right, Jill, can you put me on share screen, please?
I have done. You should
Right.
be able to. You should be able to hook up.
There we go. And I hope that you all can see a little introduction page there. It's got the Institute's logo in the middle, CPD and all the rest of it. That's good. Okay. So, nails, nails, nails. They are quite a fascinating area of the body. Well, I think they are anyway, which probably makes me quite a sad person, but hey ho, it's to do with our profession, so it's not too bad. But nails, they're a window on physiology and how the body's working. They're an indicator of disease, and they can be a very good indicator of toxicity, especially if you're a forensic pathologist and you dig up bodies or bits of bodies. They can be quite a useful area of the body to analyze, to see perhaps what killed that body. Now, I put a quote down there at the bottom from the editor who edited that book that I just showed you, Rodney Dorber, and his co-authors, his co-editors. And he said, or they said rather, the nail is an opalescent window on the body. And it's quite true, actually, because it can tell you so many things. Now, that's somebody else's quote. So I'm going to make my own quote, because I haven't made a quote for a long time. And I'm sorry if this sounds pompous, but this is something I really do believe strongly, because we are a science discipline that has cutaneous medicine dealing with the skin at its very heart of what we do. At whatever level we do it, whether we cut through the skin to get into the interesting bits in the middle of the foot, or whether we cut things off the skin, then still, the nails essentially are a very important part of the skin. They're a superficial structure of the body. And to not be fully au fait and fully understanding of nails and what they do, I think is a little bit like, in my personal opinion, a dentist not studying teeth or a dentist ignoring teeth. And I think we ignore them at our peril because they can be useful diagnostic tools. But if you understand them well, they can also be something that can give your patients a great deal of benefit if they have problems with their nails, whatever those problems are, or if they have problems with other parts of their body that the nail can tell us about. So when I was writing this at about midnight, 3 or 4 days ago, as you do, I thought, well, how can I describe the nail? So the phrase that sprang to mind was much in little. And I think that encompasses the nails very much. I can't claim originality there because one of my favorite counties is actually the county of Rutland. And if any of you live around Rutland or near Rutland, I mean, we live in Derbyshire, so we're not very far away, and we sometimes hop on our motorbikes and zoom over there to Rutland Water. Then you will know that the county motto of Rutland is much in little, which they put in the Latin form of multum in parvo. So I did think of writing multum in parvo at the top, but I thought it might be a bit presumptuous, so I didn't. So we'll stick to the English version. Right, so what I'd like to run through are the various parts of the nail that make up the whole structure of it. First of all, we've got the nail plate, what we identify as the nail itself. Now, it's an interesting tri-laminate structure, so you can compare it really to plywood, to different levels of plywood. You have the ventral layer or the ventral lamina, you have the intermediate lamina, you have the dorsal lamina right on the top. Now, the whole structure that those 3 layers make is avascular, or it is normally. You shouldn't have blood vessels running through it, although I suppose most of us at one time or another have actually cut what appears to be a nail and have a little spot of blood appear on it, which we then obviously put a suitable hemostatic agent upon. And that's simply because you've got a minor blood vessel like a capillary that's got mixed up in perhaps some of the structure under or around the nail and has been swept forward with the nail. So when you cut the end of it, you get this little dot of blood. But it shouldn't normally be there. And it's a very durable, surprisingly durable structure. And it's keratinized. So in other words, it's made of keratin. Now, as we know, keratin is a structural substance that exists in many, many different places in our body, from your teeth to your hair, to the various structures in and around other areas that need strengthening, that need something that's a bit tougher than our normal tissue. So that's the nail plate. Then we have the lateral nail folds, which we can abbreviate to LNF. Now those are the cutaneous borders of the nail itself. You then have the proximal nail fold. Proximal obviously means that it's closer into the heart or closer into the mid part of the body. And that's the visible border that is continuous with the eponychium. In other words, the cuticle. And then you have the cuticle itself. So that's the epidermal seal, which extends from the proximal nail fold down to the nail plate itself. And it seals off the root of the nail to stop nasty things getting in there. Obviously, I'm sure that many of you, like me, will have found some of the nasty things that get in there are beauty therapists with nail sticks that push the cuticle down and open it up. And then somebody comes along and they've got paronychia, they've got this huge dribbling toe, simply because the cuticle has been damaged by an overzealous beauty therapist. Well, okay, I won't criticize beauty therapists. I mean, I've never let any near my nails, but then again, I wouldn't, being a bloke. Although possibly I would. Maybe I should. Maybe that's a very sexist statement on my part, in which case I apologize for it. Anyway, you have the cuticle, which should ideally be looked after. Then you have the matrix itself. Now, the matrix is the root of the nail, and that is within the invagination that is formed essentially in the external tissue of the body. So that's where the matrix sits in. down there. If you can imagine that there's a cavity going in there, that's the matrix, that's the root. Now, the root of the nail is something that has given a lot of discussion over the years, and I'll cover that in a little bit. But to carry on with the actual visible structures of the nail, we've got the lunula. You can obviously see the root of the word then is luna, because it's the crescent-shaped part at the bottom that sits just above the aponychium. You then have the nail bed, which is the vascular bed, often quite vascular because you do have venous arches running across under that, as we find if we're doing various types of nail surgery, especially if you're going across the top and maybe doing a Winograms or a Zardix, something like that, then you certainly find that he's quite vascular down there. So that's the bed upon which the nail rests. Then you have the onychodermal band. Obviously, the preface onycho suggests that it is something to do with the nail, as it is. That's the distal, that's the farthest away margin of the nail bed itself. You then have the hyponychium, which includes a structure called the solen horn. Now that's the cutaneous margin of the nail, and it underlies the very free edge of the nail there. And then sitting under that free edge, you have what's known variously as the distal groove or as the limiting furrow. Now that's a ridge of skin, quite tough skin that sits under there. It's part of the mechanism for protecting things from going under the nail. So that's the cutaneous ridge that demarcates the border actually between the subungual structures, in other words, the structures under the nail, and the pulp of the finger or the toe in our case. So much in little indeed. You could write a lot about that. The nail itself, the nail plate, is made of a quite dramatic mixture of hard and soft keratin. So keratin is structural protein. And we know that there's at least 20 different types of keratin. Some is hard, some is soft. And these keratins arise from the matrix. Some people have said that it arises from the nail bed as well. And certainly up until and including 1954, then you had authors and researchers like Lewis saying that the actual matrix of the nail, the generating parts, included parts that generated the ventral, or it had generation cells in the ventral part and also in the nail bed. So you had three elements growing the nail. That was contradicted by subsequent researchers who said the root is the root, essentially. The nail root is the matrix, and that's where it grows from, full stop. You can't get in there and differentiate too much. So Zayas and Alvarez claimed that in 1968. They were backed up by Norton in 1971. And he said that, yes, it's just growing through the matrix. Don't get too complicated with this. Then Johnson and his friends came along, and they came along in 1991. And then because they didn't have enough in 1991, they came back in 1993. And they said, no, absolute nonsense. Some of the nail grows from the matrix itself in the invagination tissue, the root cavity that was spoken about, but some of it grows from the nail bed as well. So an argument developed on that, a professional argument. And then the people, once again, some of the people who contributed to that book that I showed you, De Burker, Angus, and then De Burker and al, et al, etc. In 1996, so two separate research articles. They said, look, nonsense, absolute nonsense, people, this is rubbish, it all grows from the matrix. So that's where we stand at the moment, unless any of you know that there's any advance on De Burker and Angus and De Burker again in 1996. It's probably something that will go round and around and around, because it can be hard to experiment on live nails. People sometimes do object to you cutting bits out of the underlying tissue and all the rest of it. But that would be the definitive way of researching it. I mean, sometimes we do have to cut bits out of the underlying tissue if we take a biopsy, for example, of a nail bed, if we think that there's a cancer sitting under the nail, something like a malignant melanoma. But usually we're more interested in actually getting a sample for the histology to prove whether it's a cancer or not, rather than doing any research on it. But anyway, those theories have abounded over the years, and no doubt they will continue for a few years yet. So, in short, what we're describing is sheets of flattened keratinocytes, that's keratin-producing cells, which are expressed by various parts of the matrix. Let's not be too dogmatic on this. And then these flattened keratinocytes, they're pushed forward along subungual ridges of vertical collagen fibers. Subungual obviously means underneath the nail. And if you look at them, if you actually remove the nail plate completely, you can see these ridges very clearly. And imagine they're like railway tracks. And those are the tracks that the nail grows forward along. Now, as we've said already, the matrix is protected from pathogen ingress normally. So as the growth occurs, these keratinocytes, they move distally, they move towards the end of the toe, the finger, if you're talking about fingers. Then as they move forward, their nuclei, bearing in mind the cells, so they have a nuclei, fragment, and the cytoplasm of the cell itself condenses and it compacts down into layers. It's quite analogous in a way, really, to the stratified squamous epithelium that we see on the outer layer of our skin, where you have these flat plates of essentially completely dead tissue that is forming a protective agent, forming a protective layer. But when all of that happens, you have a nail. Voila, we have a nail. And if my French was better, I would have said voila, and then in French we have a nail. If anybody knows how to say we have a nail in French, then please put it in the comment box. What can affect this wonderful structure? Quite a surprising number of things can actually. Toxins can affect it. Either toxins that you intended to take or toxins that you are unaware of taking. Trauma, of course, can affect it. Congenital pathologies can affect it because the actual enlage, which is the bud of the nail, forms about the 17th week of fetal gestation. So there things can happen to the fetus that can affect the subsequent development of the nail. Occupational factors can affect it. More so perhaps in the past than nowadays, because we are more health and safety aware than we used to be. So you probably don't have many ladies in factories putting their hands in chemical baths to, plate metal with chromium and stuff like that. They'll at least wear a pair of rubber gloves now, or nitrile gloves now. So they're occupational factors, but they can still exist, of course, because not everybody does their health and safety as they should do. Fungal infections can affect the nails, and we'll talk about fungal infections later at a bit more length because it's quite an interesting area. Bacterial infections can affect the nail. Not that the nail itself can really become infected by bacteria, but certainly the tissue under the nail and the tissue around the nail can become infected by bacteria, so that can affect the nail. Systemic disease can affect the nail and affect it quite dramatically. A very simple example of that would be things that affect the skin, for example. Because if it affects the skin, it can affect the nail. So psoriasis is a pretty good candidate to affect the nails. And very often people will come with some quite severely damaged nails on the assumption that they've got fungus or something like that. And you take a close look at the nail, preferably with a magnifying glass. And if you look at the nail and you see that it's got lots of pits in it, which we call thimbling, because it looks like the surface of a traditional thimble, it's got all these little depressions in it, then that's almost a definite diagnosis that psoriasis is involved. So there's a systemic condition that can affect it. Neoplasms, so things that grow under and around the nail, tumors, which can be benign or malignant, they can affect the nail, sometimes, once again, quite dramatically. You can have malignant melanomas that can form under the nail. And we're seeing those increasingly nowadays. And there can be various dermatopathologies, which can include all of the things that I've said there, but things that can affect the skin by way of eczema, etc., etc. All of those can have an effect on the nail. So the nail can be under a lot of threat. If we look at toxins in a little more detail, then due to the very slow growth of nails, especially in the case of the toenails, because as we know, well, certainly as we're told when we're doing our training, toenails can grow up to 8 times slower than the fingernails. Now, I've never actually timed it. I've always taken that as read. Perhaps when I retire, I'll do some studies on that. I'll have time to sit there and watch my nails grow, perhaps. So I'll come back to you on that subject. But due to their slow growth, the nail structures can actually form a reservoir of past factors affecting the body. They're a little bit like the rings of a tree, because you can look at the tree rings when you cut through the tree, and you can see things that have affected it, depending on the tree, maybe 100 years ago. Now, obviously, nails, toenails and fingernails don't have rings, but they can be a reservoir for factors that are affecting it. Because it can be affected by xenobiotics, such as heavy metals. Antibiotics can affect the nails. Chemotherapeutic drugs can affect the nails quite dramatically. They can damage the nails and the matrices to such an extent that the nails will fall off, as I'm sure many of you have seen. If you've had any of your patients doing chemotherapy with taxanes and things like that. Prime example, and one that I always quote, so you might be fed up of hearing me say this, is Mees lines. Now, Mees lines are a white or sometimes possibly a bluish line that goes across the nail. And those can be present in late stage arsenic or thallium poisoning. They take quite a time to develop. So when you actually see those lines, you're sometimes looking at them on a corpse, or they're pretty close to being a corpse. So sometimes they don't form soon enough for you to be able to intervene with the person and say, look, mate, sorry, somebody's giving you arsenic or poisoning you with thallium, if they want to be a bit more exotic. But those are just a couple of examples of the things that can affect it. Many other things can. You know, we can make a huge list. If you want to read more on the subject, then there's a very interesting article on the aspects of drug-facilitated crime that I put the link for under there, under the page. So you might find that interesting if you want a bit of salacious bedtime reading. And there's Mees line. Now, fortunately, this person was still alive, so I think they got saved. And you can see that it's whitish, slightly bluish sequence of lines. So obviously what happened there, and I'm assuming that it was arsenic in this case, is they had a dose of arsenic, then came pretty close to death, and then lived because the nail grew a bit more. Then they had some more arsenic, or maybe thallium, I don't know. The same thing happened, and the same thing happened again. And as you can see at the bottom, just above the cuticle, there is some uninterrupted nail growth there that doesn't have a Mees line on it. So we assume that this person survived. And perhaps the person who was responsible for poisoning them got caught. I've no idea. But that's a pretty good example of a Mees line. But some of them, as I say, can tend more towards the bluish. Now, drugs, as opposed to toxins, they might either be prescription drugs that we prescribe for people, or they might be drugs of abuse. Now, it's quite interesting, and once again, in criminal forensics and things like that, and also employment monitoring come to that, you can use the nail as an indicator of how drugs are getting into the body. So there might be prescription drugs that you want to monitor whether people are taking them, or whether people are doing things such as binge drinking, which can cause a buildup of ethyl glucuronide, whether they're taking other drugs either for recreational purposes, such as cocaine, if indeed that's a recreation. I don't know, I've never taken it, but I understand some people do, or prescription drugs such as cortisone, etc. All of those can leave a track and a trace in the nail. Excuse me, I've been doing a lot of talking today. I've been shouting at my clients today, so that's why I'm like that. So You can actually do the tracing for up to 14 months in the toenail. So if, for example, you wanted to check whether somebody was taking serious drugs of abuse, and if you were able to get a specimen from their toenail, that would be a pretty good indicator of what had been going on. Obviously, if you were going to take specimens from them, then they'd have to give you permission, or I suppose you might get a court order to, well, I'm sorry, I'm going to cut your toenail, mate. The court's giving me a warrant for your toenail. I don't know whether that has actually ever been done. I think I'll have to ask a colleague of mine, Hayden Kelly, who some of you may know, who's very, very much into forensic podiatry. He kind of wrote the book, but he has written the book on it. He's just published another one. But I'll have to ask him whether there's any record of there being a warrant put out for somebody's nail. And if not, who knows? If anybody's going to do it, it would probably be him. So I will ask him, and we'll come back to you on that. Skin conditions we've touched on. Psoriasis is an obvious one that we're always very familiar with. But other connective tissue diseases can affect them quite dramatically as well. So scleroderma, lupus erythematosus when it's systemic, for example, dermatomyositis, primary Jorgen's syndrome, etc., etc. So all of that group of connective tissue disorders can have quite dramatic effects on the nails and make them look very much like a fungal nail. So I'm sure that like me, many of you will have come across people coming along and saying, I've got nail fungus, and they show you the nails, and then you actually find out later on that they haven't got nail fungus, but the doctor might have been treating them with quite a strong systemic fungicide for 12 months, and they've been taking it unnecessarily. Not an unusual situation. There can be, as I said, occupation-related problems. One that I find quite fascinating is Victula's thumbnail. Now, okay, I know it's not the feet, but the principle is there, and I don't know. Maybe there is one for wine treaders or grape treaders toenail, big toenail. There might be, because with the Victula's thumbnail, you have food particles that literally osmosize under the nail plate, and it can give quite a lot of problems with the nail that sits on top of it. So I wonder if people tread grapes for a living. That's assuming people still do it. I don't know. Then I wonder if that has any effect. I can actually see our chair of ethics in the corner here, who's listening from the background. Do you have any idea whether there is such a thing? Have you ever come across it in an ethical situation there?
No, not really. But I know that a lot of people enjoy doing that, and then of course I don't know what the practices are, and I don't know how they enforce it. From it's not sterilisation, but from a cleansing point of view, and the fact that obviously I suppose that grapes ferment turn into alcohol, so perhaps whatever nasties are being stamped around in that nice pile of grapes probably get eradicated, who knows. But no, I'm not. An interesting thing, I'll let you know if any of diabetic people, because they're the problem, who walk around and do actually get particles of food under their nails, so that put their socks on and then have problems. So but other than that,
maybe we should reach out to any French podiatrists that we come across and say, well, this condition known as grape treader's toe or something.
Or Spanish.
Well, Spanish treader's toe, yeah. Absolutely.
Californians. Actually, that might be an interesting one, because there's probably a lot more DPMs around that in the California area that may be be quite mindful of that. So yeah, that could be quite an interesting study, actually.
Well, strangely enough, I've got a web meeting with some of our American colleagues next Tuesday.
Good point to ask.
I'll ask them, and then I'll pass it back.
Yeah, that'd be good.
Perhaps we could have a pan-national study of this, you know,
Yeah.
between
Well,
France.
especially as the Garden of England is promoting more wines and stuff like that now. So yeah, we're going to have the climate now is being more appreciated for growing, you know, vineyards and things. We've got a few in our area, so yeah,
Oh, right.
interesting.
That's happening. Well, thank you for that. We do go off topic sometimes, so
We
we're
do,
talking,
yeah.
we're talking about wine. So apologies, people. You're here to hear about toenails, not me rabbiting on about wine.
Yeah, so if you want red wine, red nails, white wine, white nails, who knows? could be an interesting factor. Discoloration of nails included.
Thank you, Bev. Much appreciated. Now, here's something. I'm sure that so many of you will have had somebody walk into your surgery and say, my doctor, or Google, or Amazon, Alexa, or my granny, or my dog have said that I have nail fungus, and they will present their nails to you, or present their foot with these claimed fungal nails. Now, so often when we investigate further, we'll find that they actually haven't got nail fungus, they have got trauma, or they maybe even have wine treader's toe, I don't know. But fungus is so commonly misdiagnosed, and so often our medical colleagues have to reach for the prescription pad and give people some quite potent cures for it, even though if you look in the prescribing guidance, then certainly the two commonest medications which are prescribed, which is terbinafine, you might know it under the brand name Lamisil, or itraconazole, which is not so frequently prescribed now because that's what they call pulse medication. So you'll put them on it for a week and then they'll come off it for 2 weeks. The reason being that it has quite a strong action on the liver. As terbinafine can do if you're on it for a long time. And really, people should have a liver function test if they're on extended periods of medication. But sometimes, you know, our dear medical colleagues will quite happily put them on this for a year, and then you'll come along and you'll do a sample, or you'll even examine the nail, and you say, I'm sorry, mate, you haven't got fungus at all. It's either trauma or something else. Talking about nail trauma, there is musician's nail. Now, as far as I know, this only affects the fingernails of pianists, harpists, and guitarists. Having said that, perhaps someone somewhere actually plays a harp or something with their toes. I don't know. It might be an up-and-coming thing, in which case you may come across musician's nail on the toes. If anybody does, then if you could send it into head office, we'd be very grateful to hear about it. And we could probably launch another research project on that. Don't know too many people who hammer their toes, but well, there is a hammer toe, isn't it? And of course, a hammer toe can quite dramatically traumatize the nail on the end of it. And it can cause damage to the root of the nail, which can then affect the growth of the root nail and so on and so forth. So the hammer is appropriate, but it's not a physical hammer on top of it. It's the hammering that they're doing to their own teeth. Now, systemic disease can cause a lot of problems with the nails. You've got nail clubbing, which is sometimes called the Hippocratic nail. It was first described by Hippocrates, appropriately enough, and he described it in people who had a condition known as empyema, which is a buildup of pus in the pleural cavity. He obviously didn't have access to x-rays or scans, certainly that would show empyema, so I presume that he noticed this on dead bodies that he cut up, and some pus came bubbling out of the pleural cavity. But it's well recognized that a lot of inflammatory diseases, pulmonary malignancy, asbestosis, chronic bronchitis, chronic obstructive pulmonary disease, etc., can cause clubbing of the nail. When the actual end of the nail, and it's the same on the toes as it is on the finger, the actual angle is rounded at the end, rounded on the end of it. And you can almost guarantee that that is caused by some kind of inflammatory condition that's going on in the person's body. It needn't be empyema, or it needn't be a pulmonary condition. It can also be cirrhosis. It can be congenital heart disease. It could be endocarditis, bacterial endocarditis, for example, could cause it, or other atrioventricular malformations can be responsible for it, as can fistulas, or even inflammatory bowel disease can cause it. It's not by itself a diagnostic certainty. So the next time somebody with clubbed nails walks into your surgery, then don't say, oh my God, you know, you've got cirrhosis of the liver. You'll need a few more tests, but it can be indicative of something that you should be looking at. So that's clubbing. Very widespread set of circumstances can cause clubbing. Then you've got koilonychia. Now, koilonychia is where you have that spoon-shaped depression in the nail. And it can occur quite naturally in a neonate. So, you know, a young baby, they can have koilonychic nails, and it can worry the parents terribly. You can reassure them and say, it'll go 99 times out of 100. There isn't a problem. It's simply part of the developmental anatomy that's taking place. But in an adult or even an older child, it could suggest iron deficiency anemia, conditions such as hemochromatosis. We could suggest Raynaud's disease quite frequently, systemic lupus erythematosus, trauma, of course, can cause it. Nail patella syndrome can cause it. So there can be a lot of reasons for koilonychia. Onycholysis, that is where the nail is actually starting to die, essentially, or being destroyed. Psoriasis, we mentioned, infection, hypothyroidism, sarcoidosis, trauma once again, protein disorders like amyloidosis, connective tissue disorders, and so on and so forth. Pitting, we've mentioned, psoriasis, Reiter's syndrome, alopecia areata. So if you notice something that's wrong with the hair, it could actually translate into the toenails. Those lines, quite interesting. Once again, they're a ridge that grows up, a transverse ridge with the nail, and these can be caused by systemic illness that disrupts nail growth. It can be caused indeed by a series of heart attacks. You can see these lines appearing in people's nails. Once again, Raynaud's disease can cause it. Pemphigus, once again, trauma can cause it. Then yellow nail syndrome. I don't tend to call it a syndrome now. We just call it yellow nail. Lymphedema, pleural effusions. So once again, that's related to the Hippocratic nail. Immunodeficiency. So people who might have AIDS, for example, bronchiectasis. Once again, it's a pulmonary condition. Sinusitis, interestingly, can cause yellow nail syndrome. Nobody knows how, but it can do. Rheumatoid arthritis, so you can see it in the conditions of that. Problems with the kidneys. Thyroid problems, tuberculosis, and once again, Raynaud's disease. So a whole range of systemic diseases can cause problems with the nail. By itself, it's not indicative of a diagnosis, but it is indicative of an index of suspicion. You know, the more you know about it, the better you can use your indexes of suspicion. Now, onychomycosis, so fungal nail conditions, often misdiagnosed, but often not. Conveniently, we can divide the organisms that cause onychomycosis into molds and yeasts. And of course, they can also affect the skin as well. Now, molds, they sexually and asexually reproduce into multicellular forms called hyphae, which they form a mat-like structure called a mycelium, which mycelium also exists with other types of fungus, because that's kind of things to be running under your lawn if you have fairy rings in it. That's assuming that they're not really put there by fairies, which, you know, my wife would say they are, but I personally think that they're more to do with the fungus. Yeasts, on the other hand, are unicellular, and they reproduce asexually by budding. So they drop a bud off to make a baby yeast. But both of those can affect the nails as well as the skin, anywhere but the skin around the nails as well. Now, we've got more than 20 species of dermatophyte mold exist, but there's only 3 of them predominantly will cause infections of the nail structure. Now, those 3 are Trichophyton rubrum, which is it's not a single species, it's a complex of species that they tend to differ very slightly depending where in the world they are. So there are geographic differences there. But they still all belong to the species Trichophyton rubrum. You've then got Trichophyton mentogryphates, which is the second most commonly isolated fungus causing tinea infections in humans, and the most common, or one of the most common fungi that causes zoonotic skin diseases. And sometimes a lot of us may actually have some Trichophyton mentogryphates and other things on our skin and not be aware of it. And I'll show you some pictures of that that suggest that and support that. Then you have the wonderfully named Epidermophyton flocosum. Now, originally it was called Acrothecium flocosum, which personally I find harder to say than Epidermophyton flocosum. But the chap who coined the name Acrothecium flocosum was beaten to it by somebody who'd coined Epidermophyton flocosum first, which I'm quite grateful for. But those are the three commonest fungi that you will, the three commonest mold-based fungi that you will have. Now, if you look at rubrum, mentogryphates, and flocosum, they all have the ability to produce enzymes. And these enzymes break down all of the four major classes of biological macromolecules, which are, of course, carbohydrates, lipids, proteins, and nucleic acids. Now, as you can imagine, the nail plate itself is a protein structure. So it's a very rich source of food for our mold friends. So if they can get in there and start eating it, so they make the enzyme to start dissolving it, and damaging it, and then they start to gain their nourishment from it, you can see the reason why they're doing this. There's a typical mold presentation, and that is demonstrating the wonderfully named, I think, distal and lateral subungual mycosis, or technically onychomycosis, but I didn't have the room to get that in one line. So I just put mycosis, which is still correct, but DLSO is what we normally abbreviate it to. As you might imagine, because we've got the name distal and lateral subungual onychomycosis, then it means that it mainly affects the end and the side of it. As you can see, there's some hyperkeratosis that is developed in a nail that is already damaged by the looks of it, because you can see those striations running forward. So something has already damaged the matrix of that nail. And of course, that nail damage may well be a fungal condition. A previous fungal condition can quite dramatically damage the root of the nail. That illustration, by the way, I've taken from an excellent website called DermNet. DermNet New Zealand, actually, dermnetns.org. And you will find that that is a fantastic source of information on any conditions that affect the skin or the nails. I've never found anything to match it. And it's free. You don't have to subscribe to it. They've got illustrations, they've got learning events on it. Tremendous. It's a great location to up your knowledge about skin and nails, and I would strongly recommend it. There's another mold, superficial white onychomycosis. Now, the commonest cause of that is tinea mentogryphates. And that presentation is the top layer of it, the dorsal plate of the nail. Becomes almost flaky, and it also then has a dappling effect to it. And once again, that's an illustration from DermNet NZ, and that shows it very, very clearly. Interestingly, if you look at the toe next to it, if you look at the second toe, then you can see that there's a very aggressively tented nail. Now, obviously, tenting of a nail can be caused by a proliferation of bone underneath it. But equally, it can be caused by some kind of physical damage, or indeed by a fungal condition as well. But it's a very noticeable tenting of that nail. And sometimes you actually end up taking the nail like that off completely, which can sometimes be the only way to make it comfortable for a person. And then sometimes you actually have to go under that and take away a bit of bone, making the nail sit up. But that does look, and it looks quite swollen as well, the end of that toe. But that is superficial white onychomycosis affecting those, and the other nails really don't look that healthy either, do they? Although I'm pleased to see that the circulation of the toes is quite good because they've got hairy toes, which, as we all know, is usually a sign of vascular health. So there's some good circulation going through those toes, hopefully, because the hairs of the toes can often be the first things that are affected by it. But once again, you've got a link under there. When I go to Dermnet's NZ and have a look at fungal nail infections, it will tell you everything you ever wanted to know about fungal nails and were afraid to ask. There's another one. Now, this is proximal subungual onychomycosis, PSO. And this starts obviously from the proximal part of the nail, or actually the matrix of the nail. So it grows forward with the nail. But as you can see, the dorsal nail plate there is not particularly affected. So that is, you know, it's still quite integrated. It hasn't been affected in the same way that the last one had been. So it hasn't gone flaky on top at all. This is something that's probably happening in the intermediate layer of the nail. And as I said at the beginning, you've got this trilaminate structure. So you've got the dorsal plate, you've got the intermediate plate, and then you've got the ventral plate. The intermediate plate, the middle plate, has in the past been called the humid layer of the nail. That's because it has a greater proportion of humidity than the rest of the nail. It's also thicker as well. So that's something that seems to affect a combination of either the humid, the mid layer of the nail plate, or even the ventral layer on the bottom. So it produces this white discoloration. And unlike other fungal nails, it doesn't give thickening of the nails. They still grow, you know, looking the normal height that they would look. Now, if any of those conditions go on for too long, then you can end up with total dystrophic onychomycosis. So that can be the potential sequel of it. And really, you look at something like that, once again, it's from our friends at Dermnet NZ. And essentially, the nail is completely and utterly, if you'll forgive the expression, knackered. It's diffuse, diffusely thickened, it's friable, it's yellowish, it entirely lacks structure. There's nothing there. The nail is literally rotted away or being eaten away from it. And that can be the sequel, the end sequel, if we don't effectively treat a nail fungus. But how do you know that what's in there is a fungus? That can be the problem. That's certainly the problem that the rest of medicine faces, because they take a look at it and say you've got a fungus, there's some terbinafine for a year. But the only way truly to differentiate with near 100% certainty is to send specimens of the nail away for histopathology, because then they can have a look under a microscope to see whether they can see fungal items within the nail structure itself. But then they can also, if they do see fungal artifacts in there, then they can try and culture the fungus from it. And I'm sure that most of you have seen the kind of culture dishes that they use, a Petri dish that's got an agar solution or an agar gel in it. And depending on what they try to culture, it can have a ring of antifungal or antimicrobial agents around the periphery of this Petri dish. And then if there's an area where if you have cultured something and it starts to spread across the dish, if it won't go to one particular part of that dish, then that can show you what that organism might be susceptible to. It can be quite useful for if you're trying to find out which antibiotic, for example, might be useful against a bacterial infection. And that's the way they do it. So laboratory testing is probably the gold standard. You've then got point of care testing. Now that does exist. There are test strips that you can buy. I've never tried them myself, so I have no experience of their use. They don't appear to differentiate between the various types of organisms. Although sometimes you don't need to differentiate. Sometimes you just need to know it's fungus and then give them an antifungal prescription. But there's another interesting way of identifying fungal conditions, and that's using ultraviolet light. Now, some of you, once again, may have experience with Woods lamps. Now, these are ultraviolet generating lamps because in 1903, a very simple method of artificially producing ultraviolet light was developed by the physicist Robert Wood, who was with us until 1955. And that's why we tend to call an ultraviolet diagnostic lamp a Woods lamp. Some of them have got a built-in shield and all the rest of it, and so on and so forth. More modern versions tend to be like that. That is a Waldmann, it's a German one, a Waldmann ultraviolet lamp, 9 watts, I think, so it's quite low wattage. When you switch it on and it warms up, and the ultraviolet tubes will start to glow, and it's got a filtering agent in these vision tubes there. And when you shine it on fungus or certain bacterial agents, it will produce chromofluorescence, which can be quite interesting to look at. I'll just put that to one side. Doing anything from the hair? No, it's all right. I haven't got fungus in the hair. That, of course, is not in the visible spectrum of light, although you can see some of the spillover of the light, because ultraviolet comes at about 300 to 400 nm, whereas the visible band tends to be 390 to 750. And although it's pretty much invisible to us, then birds and even bees can actually see it. But there's an example of diagnostic fluorescence. Now, the things that you're looking at there are actually bacterial conditions. So you've got pityriasis versicolor on the top. So as you can see, it's interdigital between the big toe and the next one to it. And then on the bottom, you have got erythrasma, as it's sometimes called, which is Cornbacterium minutissimum. And the top one, the pityriasis, glows a yellowish white. And the erythrasma on the bottom, that gives that striking coral red glowing, which indicates it's Cornbacterium minutissimum. And actually, I mean, that was done with this particular Waldmann lamp, probably about 8-9 years ago, I'd imagine. Interestingly, there are some fungi that will not display bioluminescence or chromofluorescence, call it what you will, but quite a few of them will. And there was some interesting research done in Brazil back in 2007, and I've put the research there on the bottom, and that was actually using different wavelengths within the ultraviolet spectrum, or the ultraviolet range. It was using different wavelengths to actually diagnose which particular fungi we were talking about, or which particular mold we were talking about. They have to be very accurate, but it can be you know, a very good way of diagnosing. And of course, if that could be developed, it would give us much more detail than these point of care test strips that I mentioned here, because you could point to it and say, well, yes, that's a particular fungus. I mean, we can certainly do it just by the color with bacterium quite easily. But when you have molds and yeasts fluorescing, they just tend to fluoresce white. As do other parts of the body. I mean, that's an area of skin under visible light. And if you shine an ultraviolet light on it, that's what it looks like. Now, in point of fact, that doesn't indicate that it is fungus on the skin. That's actually showing that there's sun damage, quite considerable sun damage, to that area of the skin, which you can, I mean, you can get that idea just by looking at it there. But this is the diagnostic test that there's a lot of damaged structures in the melanocytic layer of the skin, which of course generates the pigment and generates the protection against ultraviolet radiation. So somebody like that, if they're not using a really, really good sunblocker, then they're playing with fire, because there's a lot of skin there that just, has no protection from sunlight at all. So as I say, if it was a nail, if it was a fungal nail, they will glow as white as those will. But there won't be sufficient of a color difference if you're just using one single source like this to enable you to say, well, that is that particular mold, or that is that particular, that is that particular variety of yeast. Although certainly in the laboratory, they could do that if they're being accurate enough about it. And as our technology gets better, it's quite possible, I would imagine, that you could have a handheld device that you could shine on it, and it could very probably analyze which kind of fungus you've got. Now, you also have to consider tumors. Tumors can affect the nail. There's a syringofibroid adenoma, which sounds absolutely terrible, but fortunately they are benign. Syringoma is essentially something that forms around the nectarine duct, so a sweat pore of the body. And they are usually benign, although there is a malignant version of it. But various types can cause damage to the nail there, so you can quite clearly see that there's a syringoma that's formed under the nail there, because we do have sweat pores around the nail and just under the edges, as we know. As I'm sure many of you will have seen when we're doing nail surgery, as soon as you approach the syringe, the nails, the toe starts to sweat quite dramatically. See beads of sweat coming out of it. So it's got quite a few sweat pores on the average toe. You can have warts causing the same thing, causing damage to the nail, or you can have some quite fast-growing tumors, neoplasms, keratoacanthomas. Now, keratoacanthomas can be quite dramatic things. There's one on a face. They form quite dramatically, quite quickly, but fortunately, they're not malignant, and they can go away equally quickly. I mean, this person wandered into a dermatology department that I was in probably about 6 years ago now, and they had quite a few of these distributed over the body. And I thought I'd never seen something like this before, so I said to the dermatologist I was with, I said, that's tremendously, what kind of skin cancer is that? She said, not skin cancer, it's a keratoacanthoma. So well, do we send it for histopathology? She said, no, we don't send it for pathology, because if we do, it'll come back saying it's a cancer. And we know it's not a cancer, and it will go away. So about 3 months later, this person came back and they didn't have a sign of these at all. But you can get small versions of that happening under the nail. You can then have pleuromas. Now, once again, these are neoplasms that are comprised of epithelial skin cells that have tubular structures within them. So there is a malignant counterpart of those. Now, that is possibly something you'd want to actually take a sample to see whether there really was some malignancy going on there, because it's quite an unhappy toe, and I certainly don't like the look of the distal part of it, because it looks wrong. And quite often, if something is wrong, then it's worthy of further investigation. If it's the cancerous version, then you call it a orocarcinoma. Of course, we mustn't forget the big bad boy in the room, which is a potential subungual malignant melanoma, a malignant melanoma under the nail. Now, this has been marked up for biopsy. Once again, this was in the dermatology department. It was fairly obvious what it was, so we took quite a dramatic sample off that, and it came back, so most certainly as a melanoma, so we took the end of the toe off as well at the interphalangeal joint. But the person survived. It didn't metastasize. But melanomas, malignant melanomas, are becoming more common. So if you see something under a nail that doesn't look right, it might be something completely benign. And quite frequently, it's just a bruise. It's just a blood blister under the nail. But sometimes it's something more sinister. So always keep a healthy index of suspicion. And please don't end up sending everybody with a bruised nail onto the dermatology department, because they have quite a short span, before they become really frustrated. Because I know that the 12 months that I was in that department, the dermatologists became so frustrated with GPs sending them warts and skin cancers. We had quite a rash of it in the West Midlands for some reason. Maybe it was all from the same GP, I don't know. Treatments. Now, obviously, we can't really go into detail with treatments because we could have hours talking about treatments. But at its simplest, if it's a problem, you can debride the nail. You can grind it down, you can put a topical agent on it. Over the counter prescription. You can give them, if you're able to, systemic, which might conazole. I don't particularly like it, fluconazole myself. I don't tend to prescribe it very often because it certainly is harsher on the liver than terbinafine. But terbinafine, I usually have fairly good results with it. There are increasingly lasers that can be used, especially on fungal conditions. There are microwave generators that can be used to cook the fungus, I assume. Or you can just take the nail off. So you can give a PNA, so a partial nail avulsion, a total nail avulsion. If you want to get really exotic, you can do a frost. You can do a Symes terminal osteotomy if you want, which probably wouldn't be appreciated now because it ends, you actually take the end of the toe off as well and you just do a nice little flap on the end of it, and then they never have them grow or a fungal toenail again. But many different surgical procedures can be done. So say we could fill a session with those quite easily. We have to be aware of safety when we're looking at fungus nails, especially if you're going to grab a drill and start drilling. There's a particularly nasty one, and that's Aspergillium. Some of you may have come across Aspergillium fumigatum, and there's another one, Blastomyces, dermatitis, which can cause very severe pulmonary problems, including pneumonia and in some cases death. Now, I've put a little petri dish with a mating pair of Aspergillus fumigatus there. So they're actually making their progeny all around there. So if you start to debride fungal nails, even if it's a vacuum drill, then there's no such thing as a perfect vacuum drill. I know that people who sell them will contradict that, but there'll always be some leakage somewhere. So please wear a mask. It is strongly recommended when you're doing anything to the nail, especially if it's a fungal nail, because you don't want something like that crawling into your lungs, growing, then crossing over through the alveolar epithelium into your bloodstream and then circulating around your whole body and ending up in the brain. Now, admittedly, a lot of fungus isn't quite as dangerous as Aspergillium, but some of it can be quite nasty. So please do be careful out there when you're drilling fungus. And as Hot Dog says, and please be vigilant. Now, I haven't had a single question come through. Is that because I've been gabbling along so much that I've bored you all to death? No, I can see Kirsty shaking her head. Now, I must apologize to you all because we have run over by about 8 minutes. Even though, as you probably heard, I did start to gabble a bit towards the end and try and catch up.
Martin, sorry, I did put something around that peroma that there sort of looked like some hypergranulated tissue around there. Would that be the case with a peroma if it was a suspect? Because I mean, there was that dark distal patch.
Yeah, I didn't like that at all.
Yeah, yeah. Otherwise, there would be some sort of granulated tissue there, probably from affecting it, do you think? Or is that, obviously pictures are hard sometimes to tell if there are problems.
Yeah, I mean, usually, as you know, if something looks wrong, very often it is wrong.
Yeah, yeah.
So that would justify a biopsy on that.
Yeah, yeah.
Obviously to an MDT. There we go. Anybody else? Anybody else want to throw a question at us? I mean, obviously, if you have a look at the presentation later on at your leisure, when you get a copy from the head office, and if any questions, occur to you, then please, send them into the office, and the office will send them into me, and I'll do my best to answer them. But on that note, I think I'd like to thank you for coming, and it's always a pleasure to have a chat on these cold Wednesday evenings. And if you do have any ideas for some presentations that you'd like to see, then we can usually source somebody to have a chat about them. We've usually got someone in our armory who knows something about a subject that you might like to know more of. So that just leaves me to say thank you for coming, and I wish you all a good and a safe evening. All the best. Good night.
Thanks.